Welcome to the Deep Dive. Today, we're tackling something pretty intense, high-stakes medicine, really.
Yeah.
It's about cardiac arrest that just doesn't stop. We're going to focus on the strategies, the specific things clinicians are trying when, the usual stuff, the standard shocks, the drugs just aren't working. And the scale of this, it's huge. Over 356,000 out-of-hospital cardiac arrests, OHCAs, happen every year in the U.S. alone. That sheer number, it just forces us to keep searching for better answers, better ways to save lives.
Right. And when you look at those numbers, the type of rhythm matters a lot. Often what we see first in the ER are things like ventricular tachycardia, VT, or ventricular fibrillation, VF. These are the ones we can shock, and they generally have a much better prognosis than things like a systole or PEA, pulseless electrical activity, which aren't shockable.
But our focus today, where we're really diving deep, is when those better bad rhythms, VT and VF, become resistant. When they become refractory. This means that non-perfusing rhythm just keeps going despite everything the team is doing. It's maybe only 4 or 5% of VT-VF cases, but, well, these are the patients who've historically had really grim chances.
Exactly. They represent sort of the clinician's nightmare scenario. So our mission today is to give you, the listener, a clearer picture of what's happening on the advanced edge of treatment. We're going beyond the basics. We'll unpack the updated definition clinicians use before escalating care, look at some, frankly, revolutionary defibrillation techniques, explore different drug options, and finally, discuss a major advanced intervention, ECMO.
Okay, let's start right there. That definition of refractory VT-VF.
Yeah.
Because, if you're going to escalate to really advanced measures, you have to be absolutely certain you've done everything standard first. And that definition, it seems, has gotten way more specific.
Oh, absolutely. It really has. The older thinking was maybe just, 3 failed shocks. That was kind of the simple view. But the current standard, what you see in the recent literature, is much stricter. To officially call it refractory VT-VF, the rhythm has to be persistent or keep coming back despite 3 shocks, 3 rounds of epinephrine, and the proper use of an antiarrhythmic drug.
An antiarrhythmic,
Like amiodarone or lidocaine, typically. You need all 3 of those things, shocks, epi, and the drug, to have failed.
Wow, okay. That's a significant level of detail. That basically means the team has to have run through the entire standard ACLS algorithm and failed before they can even label it refractory. You've maxed out the standard electrical tools, the standard drugs, and the heart is still fibrillating without pumping blood.
That's exactly it. And hitting that point forces a complete mental shift, It signals that whatever's driving this arrest, it needs something more than the standard playbook.
And that shift, that pivot, it changes everything, even the physics of how they approach the patient. Let's talk about defibrillation, how they're literally changing the path of the electricity through the heart, starting with just pad placement.
Yeah, that's a key change. Standard resuscitation, uses that anterolateral placement. 1 pad on the upper right chest, the other on the lower left side, the flank. When that doesn't work after multiple attempts, studies are showing real benefit just by moving the pads to the anteroposterior position. So 1 pad stays on the front, but the other one moves to the patient's back, usually just below the shoulder blade.
Okay, simple repositioning. Why does that help so much? What's the physics there?
Well, it's mostly about impedance, electrical resistance, and current flow. The standard anterolateral position, sometimes the current has to travel through more lung tissue, maybe bone, which increases that impedance. The anteroposterior placement tries to sandwich the heart more directly between the pads. It maximizes the amount of heart muscle, the myocardium, that's right in the path of the electricity. You get more current density where you actually need it.
Makes sense. More direct zap to the heart muscle. But then things get even more complex, more aggressive, with something called dual sequential external defibrillation, DSED. This isn't just moving pads. This is using 2 machines.
Right. 2 separate defibrillators. It's a big logistical step up, which really shows the urgency these teams feel. With DSED, you have 2 sets of pads on the patient simultaneously. 1 set in that standard anterolateral position, and the second set in that better lower impedance anteroposterior position.
Okay, 2 sets of pads, 2 machines. How does that work in practice?
Yeah.
Are they shocking at the exact same time? Or is there a sequence?
It's a very rapid sequence. The idea is to deliver 2 big electrical hits almost on top of each other, sort of extending the shock duration. It needs 2 operators. The first one delivers the shock using the anterolateral machine.
Okay.
And then the second operator immediately follows up with the shock from the anteroposterior machine.
And how immediate is immediately? Are we talking seconds, milliseconds?
Less than 1 second. The guidelines are really strict on this. The delay between hitting the first shock button and the second has to be less than 1 second. It's meant to be almost like one single stacked discharge.
Wow. That sounds incredibly tricky to coordinate in a high-stress code situation.
Ah,
You mentioned two operators, but what else is critical? Are there rules to make sure it works right and, doesn't damage anything?
yeah, there are some really key technical points, four main ones highlighted in the literature. First, to avoid any issues with how the energy is delivered, the operators absolutely must use the same model of defibrillator for both shocks. Different models might have different waveforms or energy delivery characteristics.
Okay, same model. Got it. What else?
Second, the pads need to be placed as close as possible to the heart to optimize that electrical path, but critically, they must not be touching each other on the patient's skin. That could cause a short circuit, which is obviously dangerous.
Right, no touching pads. Makes sense. And the third,
Third, and this is a really important one, they do not use synchronization. They just deliver the shocks without trying to time them to the patient's ECG, which in VF is chaotic anyway.
and fourth.
Fourth, the energy level. They should be using the maximum biphasic energy setting available on both machines. Go big.
Okay, hold on. Let's pause on that synchronization point.
Yeah.
Normally, for cardioversion of an unstable rhythm, you always synchronize to avoid shocking on the T wave, which could make things worse, right? Induce VF. So why, in this very specific DSED scenario for refractory VF, are they explicitly told not to synchronize?
That's a great question, and it highlights the difference here. In refractory VF, the heart is already in that chaotic, fibrillating state. There's no organized rhythm, no reliable R wave for the machine to sync to anyway. Trying to sync would just waste precious time. Plus, the theory behind DSED isn't really about precise timing relative to a cardiac cycle. It's more about overwhelming the heart with energy. The idea is that the second shock might recruit or depolarize myocardial cells that the first shock missed, essentially improving the odds of terminating the fibrillation through sheer force. It's kind of like intelligent brute force.
Ah, okay. That clarifies it. This isn't finesse cardioversion. It's a maximum reset attempt for a system that's completely off the rails.
Right.
What's the evidence say? Is DSCD actually working in the real world?
Yes, the evidence is becoming quite strong now. We've seen recent trials like the DOSI VF pilot study and then a bigger cluster randomized control trial, which both showed significant benefits. Both just switching to anterior posterior placement and using DSED led to a higher likelihood of stopping the VF rhythm compared to just sticking with standard anterolateral shocks. So yeah, it's moving beyond experimental into, a recognized strategy for these tough cases.
Okay, so we've covered the electricity. Let's switch gears to the chemistry of the drugs. You mentioned earlier that an antiarrhythmic like amiodarone or lidocaine has to be tried before you can even call it refractory. But once you're in that refractory state, are there other pharmacological strategies being explored? New drug approaches?
Yes, there are. So while amiodarone has been the traditional go-to, the current guidelines, like standard ACLS, now clearly state that lidocaine is an equally acceptable alternative. So you have those two main options. But what's really fascinating, and it kind of represents a bigger shift in thinking, is the exploration of beta blockers, specifically esmolol.
Wait, beta blockers? In cardiac arrest? That sounds really counterintuitive. I mean, basic training tells us you avoid drugs that slow the heart or decrease contractility, negative inotropes during an arrest. Why esmolol?
Yeah, it definitely goes against the grain, right? But esmolol is different. It's an ultra-short-acting beta blocker, meaning its effects wear off very quickly if you stop it, and you can titrate it very precisely. The theory, especially for refractory VF possibly linked to underlying heart disease or ischemia, is that the body is just flooded with its own adrenaline catecholamines like epinephrine or epinephrine. This makes the heart muscle incredibly irritable, hyperexcitable.
Like it's just constantly being overstimulated.
Exactly. And standard shocks might struggle to overcome that intense adrenergic surge. Esmolol, acting as an anti-adrenergic agent, might help calm that excessive excitability down. There was a recent review looking at, admittedly, mostly small retrospective studies, but it suggested significantly higher rates of ROSC return of spontaneous circulation in patients who got esmolol compared to those who only got standard care. It seems to stabilize the electrical environment, maybe making subsequent shocks more effective.
Higher ROSC rates sound amazing. Getting the heart restarted is the first huge hurdle. But there's always a but, isn't there? The sources were careful to add a major caveat here.
Yes, absolutely. Restarting the heart is critical, but it doesn't automatically mean the patient walks out of the hospital neurologically intact. That's the ultimate goal.
And the data on esmolol, while showing better ROSC, was apparently insufficient to prove it actually improved those truly crucial long-term outcomes. things like survival to hospital discharge, or, importantly, the degree of good neurologic recovery.
Precisely. It seems to help with the immediate rhythm problem, getting the heart beating again, which is vital because it buys time. But whether that translates to better overall survival and brain function, well, that still needs bigger randomized trials to confirm. The jury is still out on the long-term benefit.
Okay. So, a promising tool, but needs more research on the big picture outcomes. If a team were to use it, what's the proposed dosing?
The literature suggests a specific approach, starting with a bolus dose of 500 micrograms per kilogram, and then following that with a continuous infusion, which can be adjusted, usually starting around 50, maybe up to 100 micrograms per kilogram per minute.
Right. So moving from drugs to the most advanced intervention we're discussing today, the strategy that kind of bridges the gap between resuscitation in the ER and definitive treatment. Extracorporeal membrane oxygenation, or ECMO.
Right. ECMO is a huge step. It's basically heart-lung bypass, but done at the bedside or in the ER. It's a massive commitment of resources, staff, equipment, expertise. But for refractory VTVF, the logic is compelling. We know that a large chunk of these patients, especially those resting outside the hospital, have significant underlying coronary artery disease, CAD. Blocked arteries are often the root cause.
Which standard CPR and drugs don't really fix.
Exactly. Standard ACLS treats the rhythm, not the underlying plumbing problem. ECMO changes that. By putting the patient on ECMO, you take over the work of the heart and lungs completely. You provide oxygenation, you provide blood flow, you stabilize them. This buys critical time. It creates a bridge, allowing the team to potentially move the patient directly to the cardiac catheterization lab for percutaneous coronary intervention, PCI, angioplasty, stents, to actually fix the blockages that likely caused the arrest in the first place.
So ECMO is this resource-heavy bridge to definitive care. How do doctors decide quickly who gets this bridge? You can't put everyone on ECMO, right? How do you pick the patients most likely to benefit?
That's a key question. The sources point strongly towards the ECG, specifically the one done after you get ROSC, even if it's temporary. If that post-resuscitation ECG shows ST segment elevation, that's a major flag.
Why ST elevation?
Because ST elevation is the classic sign of a significant acute blockage in a coronary artery. It strongly suggests an underlying fixable ischemic cause for the refractory VF. These are the patients who seem to benefit most from the ECMO to cath lab strategy. It tells you there's a target for intervention.
And this whole approach, ECMO for refractory arrest, it was really put to the test in a major trial, wasn't it?
Yes, the ARREST trial, published in 2020, it was a landmark study, the first big, open-label randomized trial looking specifically at using ECMO for refractory VF arrest right there in the emergency department. And the results were, well, pretty stunning, actually. Game-changing is probably not too strong a word.
What did they find?
They found significant improvements in patient outcomes for the group that received early ECMO compared to the group that just continued with standard advanced life support. This wasn't just ROSC. It included better survival to hospital discharge, better survival at 6 months, and really importantly, better overall functional and neurological outcomes. Patients weren't just surviving, they were surviving with better function.
That sounds incredibly positive. Proof that this intensive strategy can work wonders if the system is set up right. Which brings us to the crucial context, the limitations that the ARREST trial researchers themselves pointed out. Why isn't every hospital seeing these amazing results?
Right. The success seen in the ARREST trial wasn't just about having an ECMO machine. It was heavily dependent on some very specific, highly optimized operational factors within their system. We're talking about things like incredibly rapid time to cannulation, getting those ECMO cannulas in and the patient on bypass extremely quickly, and also really high-performing EMS with fast response times and advanced training.
So timing is everything. If there are delays getting the patient onto ECMO,
the benefit starts to disappear rapidly. The longer the brain goes without adequate perfusion, even with good CPR, the higher the risk of irreversible neurological injury. The ARREST trial showed what's possible under almost ideal circumstances.
Yeah, that study was done in Minnesota, right? They have a very integrated system.
Exactly. It demonstrated the potential when you have specialized training, dedicated ECMO teams ready to go 247, and the ability to get them to the patient fast. The success relies as much on that highly coordinated infrastructure as it does on the ECMO technology itself.
So it really raises that big question. Is it the medical intervention alone or the system designed to deliver it rapidly? Seems like it's both.
Absolutely. The procedure itself, ECMO, is proven effective in this context by arrest, but deploying it effectively and quickly enough to replicate those results widely, that's the major bottleneck now. It's an infrastructure challenge.
It really is. Okay, this has been a really thorough exploration. Let's try to boil it down. What are the three big takeaways for our listeners from this deep dive?
Okay, three key things. First, the definition of refractory VTVF is much tougher now. It's not just a few failed shocks. You need 3 shocks, 3 rounds of epi, and an antiarrhythmic like amiodarone or lidocaine to have failed. It sets a high bar before escalating.
Right. Second takeaway.
Second, the physical approach to defibrillation has evolved. Evidence strongly supports moving to anteroposterior pad placement and, in really resistant cases, using that coordinated two-machine strategy of dual sequential external defibrillation, DSED.
Got it. AP pads and DSCD. And the third key point.
Third, for select patients, particularly those with ST elevation on their ECG suggesting a fixable blockage, ECMO offers a potential life-saving bridge. It buys time to get them to definitive care, like the cath lab, and the ARREST trial showed it can lead to dramatically better survival and functional outcomes if deployed rapidly.
Okay, so a stricter definition, new defibrillation tactics, and the potential of ECMO as a bridge.
Mm-hmm. And taken together, these shifts really show a growing realization in emergency medicine. When the standard ACLS algorithm isn't working for VTVF, you can't just keep doing the same thing. You have to be ready to escalate quickly, decisively, with these more advanced, specific interventions.
So what does this mean for you listening? It means that even in these incredibly dire situations, refractory cardiac arrest, we're actually making progress. Outcomes that might have seemed almost impossible just years ago are now potentially achievable. But, and it's a big but, it depends heavily on having the right resources and systems in place.
Exactly. Which leads perfectly into a final thought, something for you to really mull over. We talked about the ARREST trial and how its amazing success hinged on things like lightning-fast EMS and super quick cannulation times often found in specialized centers. So the provocative question is this. Thinking about typical hospital systems, both in cities and rural areas, what fundamental changes in EMS funding, paramedic training, maybe hospital regionalization or specialization strategies would actually be needed to make those kinds of positive ECMO outcomes a widespread reality for most refractory VF patients, not just the lucky few who arrest near a top-tier center? How do we bridge that gap?